Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Joining me today is Dr. Randy Clements. Thanks for joining me today.
Yeah, thank you for having me.
So you are the residency director at the Carilion Clinic in Roanoke, Virginia. You're heavily involved with ACFAS. You are the president of the Virginia Board of Medicine. What do you have time left over for? That's a lot of stuff going on there.
Well, I try to stay busy. I'm also have a family, wife and 3 kids. I have a 17-year-old son, an almost 16-year-old daughter, and an almost 13-year-old son. And we're busy trying to find a good college for my senior in high school to land. So we're having a good time on the college search.
Yeah, I bet. I remember those days. They're long ago now. So how long have you been residency director?
We've been at it about 12 years now.
Obviously, for any students listening, it has a really good reputation as a solid program, one of the top tier programs. So hats off for that, because I know it's a lot of work to run a residency program and maintain all the off-service rotations and all the stuff that comes along with that. How'd you get involved in being the director?
Just vision, saw the opportunity. Carilion is a large level 1 trauma center in Southwest Virginia. It's really the only major medical center from Charlottesville to Richmond to North Carolina. Anything that services the Southwest. We're really the only level trauma center that services Southwest Virginia. There's some other hospitals, but we've been educating residents here for a long time, and we had an established GME office. I saw the need. We had a great relationship, still have a great relationship with the Department of Orthopedics and the other essential subspecialty services to complement a residency. So we took a swing at it, and it's been a ride, but it's probably been the most prized achievement of my career is to be able to educate those kids.
Yeah, absolutely. So, I get a lot of students that listen. So talk about your residency for a minute. You guys take 3 per year, and kind of give anybody listening a kind of a rundown on your program, why they should come check it out.
We're very busy, very diverse, fairly wide array of elective and non-elective surgical cases. We manage a robust inpatient service. We keep anywhere between 15 and 20 patients on there at all times. We give the residents a ton of autonomy here. So they are literally thrown into the deep end, and they're obviously, well supervised, but we give them what they need to learn in terms of support, but we also give them enough freedom so that they, feel a lot of personal responsibility for the care of the patients. We have a great clinic. We cover 5 locations. We have a wound center. Each of the residents graduates with about anywhere between 11 and 1,300 cases. It just depends on how tired they get of logging cases towards the end of their 3rd year. We all know how that goes.
Oh, yeah.
But the ones who put the numbers in are, up around 1,300. But most people are averaging well over 1,000, and it's an equal balance at the end of each resident cycle. I look at the numbers, and it's about 50 to 55% rear foot and 50 to 45% forefoot. So it's a good balance. I think they get what they need, and the testament to our residency is where they go. I have had the privilege of placing the first academic podiatrist at the University of Virginia, which was great. And she's doing a wonderful job there. We have one at UPMC at one of their satellite locations, and one at East Carolina University within their orthopedic department. So I really like where we're placing them, how we're spreading our brand, and the work that they're doing once they get out.
Yeah, absolutely. So from your standpoint, what do you guys look for in a resident? I know that's kind of hard because a lot of times people look maybe okay on paper and then they show up. And I remember back in residency, within 5 seconds, I could decide, nope,
Yep.
you might look good on paper, but nope. So what are you looking for in a resident?
Well, I've stopped looking at the paper for that reason.
Yeah.
Because, we give them a lot of autonomy here, as I said before, and what I look for is someone who can be a direct extension of us while we're home sleeping. So when they're in the ER, I want someone who has high character and someone who's going to do what I want them to do, even if I'm not looking. And you can't see that on a transcript. You can't see that on a letter of recommendation from their biochemistry professor. So I don't even look at any of that stuff. I look at their personality, and I value a lot of, I put a lot of value on emotional intelligence. And I have just kind of an internal equation that I run in my mind of, what is their IQ EQ ratio? And if their IQ is high and their EQ is high, they're going to be a winner. If their IQ is high and their EQ is low, it's going to be hard for them to succeed here. So I usually pass on those kids. So I'm just looking for someone who's going to be a good representative to us, and someone who is teachable. That's hard. But really the most important thing is who comes with characteristics that can only be taught by their parents. Personal responsibility, respect for others, and those things are more valuable than academic success. You can't judge their likelihood of being a good resident by their transcript. You can judge it by their character, though.
Yeah, I think that's well said. And it's a little alarming how often it happens the other way, where there are people who aren't hitting the target on either of those indications, whether it be DPM, MD, whatever. In residency, we interact with a lot of other specialties, and some people just like, how did you get this far? I don't even know how you got this far.
Yeah.
But, a little scary, but, show up early, do a good job. You care about your patients. You want to do a good job. You don't ask to leave early. I mean, there's a lot of simple things that residents, or I should say externs, can and should do that surprisingly set them apart from a lot of other people that seem kind of common sense things to do. So you also serve as the president of the Virginia Board of Medicine. I want to stop and say that again for people who aren't listening. You are the president of the Virginia Board of Medicine, not podiatric medicine, Board of Medicine. Can you talk a little bit about how that came to be?
Yeah, so I, let's see, 12 years ago, I was appointed by the governor at the time to serve in the podiatry role. So the Virginia Board of Medicine is made up of 4 citizen members, MDs, 1 DO, 1 chiropractor, and 1 podiatrist. And I was the gubernatorial appointee for the podiatry spot. That governor left office. I was reappointed by the next governor. And then I termed out, took 4 years off. And then our new governor, Glenn Youngkin, reappointed me when he was inaugurated. And so I started that in June of 2022. As you would imagine, there's a lot of turnover on these boards since they're appointed by the governor. So there's a lot of people who don't get reappointed for a variety of reasons. And I happen to be the guy who is sitting there who had a lot of experience from my previous 2 terms on the board. And the board voted for me, and they put me in that role. And then I was actually I was voted to be the president, to serve as the president again in October. So I'm actually serving 2 terms as the president. But that's the pathway. You get appointed by the governor to the board, and then the board members put up a ballot, and then they vote on who they want to serve as their president.
That's impressive. I think that speaks to your character among your colleagues, DPM and otherwise. So I think that's fantastic. What is your role both on the board and then now as president? What do you do on a not a daily basis? You have a full-time job, but what is your role within that board?
So the majority of what the board handles is licensing issues and professional conduct issues. So that consumes about 80% of the time working through licensing applications and board complaints for a variety of things. And then about 20% of it is legislative and regulatory in nature. So we work with some members of the General Assembly on legislation that the board needs, or we work with the General Assembly for legislation that is passed that they need us to adopt regulations for that legislation. So about 20% of the time, the legislative committee spends working on adopting regulations that complement the legislation that the General Assembly had passed in the previous session.
So does that involve scope of practice type of stuff, or is that ever come up as an issue in your state?
It has not. There are some scope of practice questions that I will get from time to time, but Virginia has done a really good job of offering a fair scope of practice, and the podiatrists within the Commonwealth have not contested it. And for the most part, we stay in our lane. We do what we're supposed to do, and we don't push the envelope too much. So the scope of practice issue for podiatrists is essentially a thing of the past, in my opinion. It's well established here. Our scope is well established, and people do good work here. So I'm fortunate that I haven't had to manage that. There are other professions that scope of practice is a topic of discussion: nurse practitioners, certified nurse midwives, PAs. There's a lot of scope of practice expansion that's happening to solve our access problem. We have a lot of rural health areas in the Commonwealth where access to care is tough. Unlike Northern Virginia, where there's tons of people, there's other areas of Virginia that are very rural, and those folks have a hard time gaining access to primary care, for example. So we're trying to find some solutions. So there is some scope of practice things that are happening outside of podiatry.
Have you had any issues serving as a DPM, as the president of the board of medicine? Probably not the people that voted you, but anyone outside of the board. Have you come into any issues of saying, like, why is there a podiatrist on the board of medicine? Like, why do we have to deal with this guy?
Not once.
Good.
No, not once. I've said this for years. I've never. My father was a podiatrist, and so I knew that that attitude or that opinion of podiatrist exists in certain places, just because of growing up with it. I have never felt it. I never felt it in residency. I've never felt it in practice, and I've never felt it in my role as a board member or the board president.
Good. That's good to hear, because you might think that would be an issue. So an interesting spinoff on you being the president of the Board of Medicine there is that Iowa was recently involved in discussions of, so in Iowa, we have the medical board, DOs and MDs, and then there's a state podiatry board. Mm-hmm. And they had discussed combining them together, and the podiatrists here had fought to keep it separate because they didn't want to lose their voice. They didn't want to be brought under this same umbrella of another, type of physician and then lose our ability to have our own voice, scope of practice. So I think it's interesting that we here in Iowa fought to go in a different direction, but it seems to be working pretty well in your situation.
And it works well in most of the states that have it combined. When I finish my term on the board, I may travel around the country to states that are considering it and talk to them about the advantages. I think the advantages are far outweigh the disadvantages.
So what do you think are the advantages? This is selfishly me wondering, because my wife is on the board of the state of Iowa here for podiatry. So what are the advantages in your mind?
I think the main advantage is that it speaks to the parity argument that we've all made for years. And when we ask for parity, we can't also ask for exceptions. And a centralized medical board is a step in that direction. And it's us being consistent with our narrative about the parity that we want within the medical community. And I have never once felt like the board doesn't judge us properly. I've always felt that it's been a very fair probable cause process for any sort of disciplinary action or standard of care action. And I'm not saying that boards of podiatry are not able to do that, but I also don't think that combining them would put that due process at risk. I think it would only make it stronger. And I think that it would only make our presence in the medical communities within those states where they're separate, I think it would only make it stronger.
Sure. I mean, I think that's very reasonable. So speaking about parity between DPMs and MDs, there's been some, it's easy to say from afar that we want parity. And I've always said the best way to get what you're asking for is to just keep your mouth shut, do a good job, get good training, do good surgery, show that you're out there and earn it, as opposed to shouting from the rooftops. What are your thoughts on parity between MDs, DOs, and DPMs? Do we need to talk about it a lot, or should we just be doing a good job and let the cards fall where they may and just be thought of as a colleague? Because on a daily basis, all of my colleagues, they don't say, oh, there's the podiatrist. They just say, there's Dr. Dikis. They don't, separate that out. So what are your thoughts on parity between the two?
Yeah, I think the first thing that we all have to, is as hard as this may be, the parity word that is applicable is doctor, because we have gone through very rigorous school. We have gone through very challenging residency times and experience. That's not an easy thing. We learn a lot. So we do deserve parity when it comes to the title of being a physician. I don't think that we deserve parity when we try to compare ourselves to orthopedic surgeons, because their pathway to get there is harder. Their residency experience is harder. The people who match into orthopedics are the elite in medical school classes, and there's no other way to put it. And just because that we have some crossover in anatomy doesn't give us the right to say that we are equal to them, because we're not. They are the cream of the crop, and their residency experience has exposed them to 2 times the training that we get. So I think that we deserve parity in terms of being called a physician. But I'm not sure that when we speak the word parity, that we should try to ask for parity with orthopedic foot and ankle surgeons, or orthopedic surgeons for that matter, because I just don't think that our experience matches well enough for us to have a successful argument against that.
Sure. So what would you say? I mean, there's a certain group of people who argue that podiatrists should take the USMLE. I'll get your thoughts and then I'll give you mine.
I think that would be a reasonable thing for us to try. I have not thought a whole lot about the USMLE and its effect on, how we would be viewed. What I do think that we should do, if we're talking about a standardized test, is that we should have a combined national society that includes orthopedic foot and ankle surgeons and podiatrists, much like the hand society.
Mm-hmm.
So if you're a member of the hand society, you can get in as a plastic surgeon, you can get in as a general surgeon, you can get in as an orthopedic surgeon.
Yeah.
So I think that we should have a combined society, and there should be a standardized test to get into that society, so that everyone would have a respect of the base competency level of everyone who's in there has passed this test. I haven't given a whole lot of thought to the implications of the USMLE and what that would do. I'm not sure that our podiatric school curriculum would prepare us well enough for that.
Yeah,
but I haven't really thought much about it. I'm sure the schools could adapt their curriculums to prepare the students for it. I just haven't thought much about that. I'm thinking more about postgraduate standardized testing, and I think the best way to do that would be with a combined society with a mandatory test entry into that, like the Hand Society has.
I think that's very reasonable. I've never thought about that before, but as you say that, I think that's a great idea. My thoughts on the USMLE are that it would be a complete disaster. The reason is, if you flip the script and you had any MD or DO take our boards exam, they wouldn't have any idea what they're talking about. Subtalar joint neutral. They'd have no clue what is going on. And that's because we split paths. We start with a lot of the same classes. My wife teaches at DMU. They start with a lot of the same classes, and then they veer off, and we become hyper-specialized, and they go down a different path, training for the USMLE. So anyone listening that thinks that we should just take the USMLE, I think that would backfire and be a complete disaster. And I don't think it would garner the amount of respect that you think that it would. So I like your idea better, because that's a way to show parity among someone who's in the same quote unquote specialty, at least foot and ankle world. I think that's a very reasonable. Let's go ahead and start that. Let's start it right now. Let's start a society, you and me right now. We're going to get it going. I think that's a fantastic idea.
All right. Let's do it.
So you're involved with ACFAS. How did you become involved with ACFAS?
Became a member, became board certified, became a member, started attending conferences, started teaching surgical skills courses, arthroscopy courses, got an opportunity to lecture for the first time. I think that was in maybe Phoenix 10 years ago. So far, people like what I have to say, and they keep inviting me back.
That's a good sign.
I guess. It's short-lived, though,
Yeah. Yeah, I started this podcast, and all of a sudden I'm speaking here, I'm speaking over there. It's just like, once they find some people who seem to have half a brain in their head and can say some things, they're like, that's pretty reasonable. They just keep asking you. So that's a good sign, I think. So how do you balance all the involvement with all these things? Because my wife wanted to know, because she's on the board of podiatry here. She teaches at the school. She's involved in the residency. She does a lot of things, and she's pulled in 10,000, and we have 2 little boys, pulled in 10,000 directions. How do you manage all these things, keep all your different duties straight?
Well, I compartmentalize a lot of things, and I get up early, and I'm always on my phone, always trying to just nibble away at tasks. And I don't think about it. I've done it for so long now. I'm just kind of conditioned to being pulled in all these different directions that I don't think much about it. But I don't lay down a lot, I can tell you that. My body's not horizontal very often, and when it is, it doesn't stay there long.
Yeah. So you and I were talking earlier about the future of podiatry and where we see the profession going into the future. So let's dive into that for a little while and get your thoughts on what you see as the future of podiatry moving forward.
Well, I think we've reached a place. I'm again, my father was a podiatrist, and I've kind of seen this profession evolve, and we have definitely made significant progress over the past 50 years. And I don't think that I never thought the first day that I walked into Temple, I never thought that my career would be where it is. So I am indebted to this profession for several reasons. It gave me a wonderful childhood growing up. My dad enjoyed a nice practice, and it gave me and my family a lot of nice things, and it's done the same for me. So I have nothing bad to say about the profession. I think it's a wonderful career. I think we do great things, but we always have to be mindful of how things around us are changing. And the people who were in charge in the 60s and 70s, we're starting to see a lot of that strategy get outdated. And I think our generation needs to adopt a strategy that's going to position the profession for success for the next 20, 30, 40 years.
Mm-hmm.
I think the biggest issue or the biggest concern that I have right now is what role will expanding the schools have on the quality of applicant, and what role will it have on the quality of the resident experience if we keep the model the same as it is now?
Yeah. So the model right now is that we don't have enough people applying to podiatry school to have as maybe good of quality of candidates as we would like. That filters in through the residency. And right now the model is backfilling with fellowships. Sometimes, I don't know how to word this. There can be very, very good residents who go to a great residency that want to do something different and hyper specialize and go to a fellowship. And there can be people that maybe don't get enough training or inadequate training in a certain area that go to fellowship. And so I just wanted to put that out there, and then I'm going to let you keep going. So the model right now is maybe we have not enough good applicants, maybe too many schools, maybe not enough good residencies, and we're backfilling with fellowships.
Yeah. I don't know if we have too many schools, because we clearly are all very busy. And so that tells us that there's not enough of us out there.
Sure.
We're not as rare as neurologists, but, it's hard to get an appointment with you. It's hard to get an appointment with me. And it's not, you can't call at 10 and get an appointment at 4. It just doesn't work like that. So I think that expanding the number of schools for the purposes of meeting community access demands is correct. The problem that I have is, how do we preserve the quality? And I think part of our strategy for the future is to uncouple the required surgical training from, I think the next step for us is we need to uncouple the requirement for 3 years of surgical training from people who maybe don't want to operate. And the example that I'll give you is, if you're at an MD or a DO school and you get to your 3rd year and you've done some surgical rotations, and you realize that you don't want to do surgery, it's not for you, you have an option. You can go into radiology, you can go into internal medicine, you can go into pathology, you can go into a variety of other very important medical subspecialties or medical specialties that don't require you to be a surgeon. In podiatry, we don't have that option. And we have a lot of folks who either self-identify or are later identified by their residency teaching faculty that you probably shouldn't be doing this. And if you are doing it, you should do it at a limited role. And I'm fearful that if we don't protect the quality of the students coming in, that number of people who meet those criteria is going to expand. So we have to create a home for them. And I think that we should take a lesson from the MDs and the DOs, and we should offer a non-operative career track, because it satisfies the access issues that our communities have. It doesn't force someone to go do 3 years of surgical training if they don't want to. And it, more importantly, for the people who do want to do it, it preserves the quality, because it's going to be a lower number. There's not going to be a dilution in minimum activity volumes or whatever could happen. And so we set it up like the dentists and the oral surgeons. So we, as a profession, we identify a number of people who we think, and just to throw out numbers, if there's 600 students in school right now, we'll say that 250 of you we're going to approve 250 4-year surgical training spots. The rest of you are going to go and do 1 year somewhere, and then you can go and have a non-operative practice. You can do, the bread and butter podiatry things. And then we're going to create a separate group of people that are going to go and become, oral surgeons. And I just think that's the way that we preserve the progress that we've made in surgical ability and aptitude. If we continue down this path of complete inclusivity, I think we're setting ourselves up to do some damage, because not everybody wants to do it and not everyone should do it.
Yeah, let's go back for some of the younger listeners. Let's go back for a minute, because that's not too dissimilar from how it used to be. First of all, there used to be no residency, and then 1 year, and then 2 year, and then there were some 3 years, but also some 2 years, and it was a little discombobulated, but it wasn't uncommon for there to be an option for people to do less years of residency, get out sooner, but not have quite the training as someone who went to a longer residency. So it wasn't too long ago. It was, I don't know what it was like when you were a resident, but it was not long before I went into residency that they switched them all to a 3 year. So just for anyone listening, this is in the very recent past that this is the way that it was.
Yeah. The problem there was that we had 3 different structures. We had the PSR 12, the PSR 24, and then we had another like PPR or something like that. And so there was no consistency amongst the trainees. And we're doing that right now with the fellowships. The fellowships are essentially bringing us back to where we were, because now you have people who've gone to excellent surgical residencies who don't go on and do fellowship. And then you have someone who hasn't gone to such a good residency, but they go on to do a fellowship. So then the hospital credentials committees are saying, oh, well, this person's fellowship trained, so they must be better than the person who's not fellowship trained. So we're essentially reinventing that now with the explosion of the fellowships. And I don't want to get off onto my soapbox on this, but I will for just a second. If we're going to continue to promote the expansion of fellowships and fellowship opportunities, we also need to require some accreditation. And if the residencies are accredited, then the fellowships need to be accredited if we're going to promote that. Mm-hmm. Because right now there's no way to standardize that experience for people. So hospital credentials committees, they don't understand, who's who now. And it's essentially one's a PSR 12, one's a PSR 24, and one's a PSR 36. We're right back to where we were before.
Right.
But it's an unintended consequence of the fellowships.
Yeah, when I came out of my 3 years at UPMC, I didn't even consider a fellowship. I was like, I'm ready. This is it. I did everything. I don't know what else I could possibly stand to learn. So, but I understand not everyone feels that way. So what are your thoughts on fellowships? Because I noticed if you go back, you said that in your model there would be a 4 year, so a 4 year residency. So same length of training is what you were thinking. But are you pro fellowship or a little suspicious of some of the fellowships getting, paying someone not very much money and getting free labor essentially?
Yeah, well, that's the reality of it. That's the reality of what it is. I am pro education.
Sure.
So if that additional year of fellowship is in the spirit of education, I'm all for it. Unfortunately, it has taken a different path, and I think it's now it's the spirit of entrepreneurship.
Yeah.
And it's not in the spirit of education. So
some of them are. I would argue some of them are, but not all of them.
Some of them are. But my point is the way that we filter out the ones that are started in the spirit of entrepreneurship is that we require accreditation. And if they don't want to do that, then they don't have one. But I can tell you that, and any residency director who's listening or you've had on before, I would bet that each of them have told you that being a residency director has nothing to do with entrepreneurship. Mm-hmm. It has all to do with education and altruism. And I think that's what fellowships should be also. And some of them are. You bring up a good point. There are some, and I could name them, but some aren't. And I think we need to figure out a way to regulate that. And accreditation, to me, is a very simple thing to require.
Mm-hmm. You think that'd be done on the state level, national board level, someone like ACFAS doing it, or just some
CPME should do it.
Yeah.
CPME should do it in partnership with the two surgical boards, and they should design a curriculum, and the accreditation would come from CPME, and if they weren't familiar enough with what the guidelines should be, then they should partner with ASPS and ACFAS, and they should come up with a curriculum.
Mm-hmm. So what do you think would make an accredited program? What do you think? Because we can, on the surface, you and I can both think of good fellowships and maybe some fellowships that are the opposite. But what would, in your mind, what would make an accredited fellowship?
You have to be able to provide something unique. You have to be able to provide something that's different than a residency experience. Otherwise, you're just cheap labor.
Mm-hmm.
So if you're at a major university and you have a robust limb salvage service, and you think that the way that you save legs is novel and deserves to be taught to other people, then you would have a fellowship that specialized in limb salvage, and there would be a curriculum for that. And there would be performance metrics that particular place would have to meet. There would be milestones that the learner would have to meet. Same is true if you work somewhere and you do a bunch of ankle replacements. You would have a fellowship in arthroplasty. Mm-hmm. So I think that the way that I would envision that we set it up is each fellowship would essentially give you something special. If it's sports, if it's peds, if it's limb salvage, if it's arthroplasty, trauma, whatever it is. And then we would set up some milestones for those programs to follow, and some performance metrics for those programs to follow. And if they can't stay compliant with them because they don't do 50 ankle replacements a year, then how's that much different than the residencies now?
Mm-hmm. Yeah, I agree with you. I think that's all very reasonable. So going back to your proposed model of surgical versus non-surgical, that's not even, you mentioned a bunch of non-surgical specialties of MDs and DOs getting to the end of their training and deciding not to go into surgical specialty, but orthopedics even has non-operative sports medicine. So it's not that dissimilar from some components of orthopedics where they have some non-operative orthopedic specialists in their field as well. So it's not that crazy. I mean, it might be a little difficult if there are, 251 qualified applicants for 250 spots. It might get a little tricky, but I don't think it's all that crazy what you're proposing.
Well, in orthopedics, they have thousands of people who apply for orthopedic residencies, but they don't have thousands of spots. Mm-hmm. So a lot of times what those students will do is they'll take a year off and go somewhere and do research, or they'll go do a prelim year somewhere else and they'll reapply. Mm-hmm. So if they don't match the first year into the surgical residency, that doesn't exclude them in perpetuity. They can go do something, boost their resume, and reapply. Same is true in the oral surgery model. They have more kids that want to be oral surgeons than they have spots. They may not get in the first year, so they go do something else for a while and they reapply.
Mm-hmm. So what would you say to any younger person listening? You kind of touched on a little bit earlier and said that the field of podiatry has been very good to you. But what would you say to anyone listening who's in undergrad or interested in the field, who wants to kind of dip their toe in the water, for lack of for use of a bad pun, of discovering podiatry and figuring out what it's all about? What would you say to young people interested in the field?
Go visit with a couple podiatrists in your community. If you're in undergrad, spend an afternoon with 2 or 3 podiatrists in the town where your school is, or nearby. And from that time, I think you'll appreciate the diversity that the profession offers. You can do a lot of things. You can do peds, you can do diabetic feet, you can do primary care, you can do trauma, you can do all kinds of things. Mm-hmm. And that's what's uniquely beautiful about what we do, is there's a lot of pivot points in it. If you want to change your practice focus, you can do that. What else?
What are some of your favorite cases? So you talked about, diabetic limb salvage and trauma and sports and all that stuff. What are you into? What are some of the things that you like to do and treat?
Yeah, I like broken bones a lot. I like broken bones a lot, and I like surgery that works. And not all of the surgery that we do has the best results. And I've told several people at conferences that my very last talk is going to be, before I retire, it's going to be, this foot surgery doesn't work, and I'm going to list out all the ones that over the years don't work.
Don't
And
wait. Don't withhold that from us. We need to know that now.
and there's a lot of them out there, and we continue to teach them and we continue to do them, but the long-term follow-up is they just don't work. So
Yeah.
I've been at this a while now, and I've struck out on some things over the years, and I've gravitated away from it. I'm not a big fan of Charcot surgery. It's very expensive. It's very labor intensive, and the results, I'm not sure that they're what we want them to be.
It's either lose or win and then lose. It feels
Right.
like it's an uphill battle for these
The whole
people. It's
time,
really
every
tough.
time. So, I like fracture care because, that those people are really grateful for what you do. I like arthritis care. Those people are very grateful. Ankle fusions, ankle replacements. I've started to do a lot more ankle replacements in the last, 6 to 8 years. Those people are some of the happiest that I have. The best operation in foot and ankle surgery is an MPJ fusion. I could do them all day long.
I agree.
They're happy. They work. Very rarely are people dissatisfied with that. Even active women who like to wear fancy shoes, they find a way to still be happy with that surgery, even though it runs counter to what we were taught in school 20 years ago. It's just a great operation. So arthritis management and fracture management are my go-to.
Yeah, my first MPJ patients, they seem to not come back. And that's all I'm trying to do. I'm trying to get people to not come back. And they seem to not come back. Every now and then there's a little issue here and there, but that surgery seems to be very reliable. So talking
Every
about
time.
total ankles, seems like the implants, when I was kind of going through school, that people were kind of doing some of them, and there was a higher maybe failure rate or subsidence and all that. And some of the implants have become, just like with anything, they've become better and stronger and better materials. So it seems to be that ankle replacements are starting to take the place of ankle fusions. What are your thoughts on your indications at this point? Because the indications seem to be widening by the day. What are your indications for someone who gets a fusion versus might be a candidate for a replacement?
Yeah, I have broadened my indications a little bit because of the experience, and the implant industry has really helped us here.
Yeah.
When you and I were in training, there were one, maybe two platforms that were out there, and there was no revision option. And now, one vendor has a primary, a revision to the revision, and they have, patient-specific instrumentation. All of those things make it easier for us to do it reproducibly. So I think that's the reason why my ankle arthroplasty numbers are growing and my ankle fusion numbers are not. I still do a lot of ankle fusions because in Southwest Virginia, we have a lot of diabetes. We have a lot of people who have hostile skin from venous insufficiency, whatever, and they're just not candidates because of those two things. Neuropathy is a absolute contraindication for me. Anyone with obviously a prior infection or anything like that. But I have expanded my arthroplasty practice because I just have more confidence in the implants. And I would encourage anybody who's doing it, pick a vendor and stay with them, because that's not something that you really want to learn and relearn. Yeah. Pick one and master it. And the system that has, all the things for me, the primary, the revision, the secondary revision, and the PSI. And I just think it makes us better at doing our jobs, and it gives us a backup plan in the event that there's a problem, which we didn't have when you and I were in training.
Right. Do you have an age cutoff for your youngest that
I'm driving them down now, for sure. I'm driving them down. I never thought that I would do one who had a 3 as their first number in their age, but I've done those.
Mm-hmm. I guess time will tell, but they seem to do okay, at least initially.
We'll see.
Yeah.
Yeah.
Don't know until you try.
The real problem is we have so many trauma patients that get post-traumatic arthritis, and ankle arthritis is a disease of younger people.
Mm-hmm.
Knee and hip arthritis is a disease of older people. So we're trying to do things that are making people comfortable during the working part of their life. And I'm not sure a fusion does that, particularly if you're considering the chances of juxtaarticular arthritis and all the other consequences that come of an ankle fusion. It's great for pain control. It's great for eliminating or reducing pain, but there's consequences that come of it. And when we first started doing this, the age was 60, and then it kind of started creeping down. But what I have found is that ankle arthritis is a disease of the younger people. They have an ankle fracture when they're in college or whatever, and they get arthritis when they're 35. And I think we trust the implants, we trust the technology, we trust the companies that are out there with these super smart engineers putting these things together. And I'm driving it down for that reason. I want to try to get people more functional during the working part of their life, which is that's a key difference between ankle arthritis and knee and hip arthritis.
Yeah, and I think having the revision options is the key there, because prior to having the revisional options, it made it a lot difficult. If you're going to do that on a younger person, what's your backup plan? I always talk to the students, and in my own brain, I try to say, okay, I'm going to do this, but if this doesn't work, I'm going to do this. And if that doesn't work, I'm going to do this. So having those revisional options, I think, is a game changer. So anything else that you'd like to touch on?
No, I'm good. The only other thing I would say to folks is, one thing that we kind of hear in healthcare, and we touch on it, but we don't really give it the credit that it deserves, is burnout and professional fatigue.
Mm-hmm.
And, I may be making assumptions here, but, your podcast that we're doing, this is a parallel passion for you. This is a distraction from your job. This is a distraction from your clinic. It gives you some joy that doesn't involve going to your office, doing charts, and doing all the things that are just constant beatdowns for us.
Yeah, I make $0.
What's that?
I make $0 doing this.
Yeah, right. Exactly. But the only way that you can sustain a career in healthcare now is to have a parallel passion.
Mm-hmm.
You've got to find something else that brings you joy, because you need a distraction. You need a healthy distraction now. But more importantly, as you transition to retirement, if you haven't developed a parallel passion throughout your career, then you're just going to retire and go home and wait to die, because you're not going to have anything to do. So I think a lot of people get consumed with their career, and then they lose this other side of life that's out there. And, and I'm guilty of it. I'm the first one that I'll stand up at the burnout meeting and say, hey, I'm Randy, and I'm the guy, and they'll put me through whatever this 12-step program is for burnout. But,
yeah,
you have one chance to define your professional boundaries, and you have one chance throughout your career to develop a parallel passion. So I would encourage everybody who's listening here, go out and do the best job you can for your people. Always be supportive of your career, volunteer in your community, take care of yourself, and find a parallel passion.
I think that's fantastic advice. I think we'll leave it off there on the fantastic words from Dr. Randy Clements. Thanks for joining me tonight.
You bet.
Thanks, everybody, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you next time.